Good afternoon. For those of you who are new to this talk today, my name is Tim Estelo. I'm an occupational therapist from the Children's Hospital of Philadelphia. I'm excited to speak to you today about occupational therapy best practice for the Walkers Group. For those of you that joined us yesterday, I'm sorry, but you're going to be stuck with me for another day. Not only for one half of the talk, but for both halves. I'm going to cover both the adult and the child side. Don't worry, I won't talk too long. I know that we have plenary talk to get back at 2 o'clock or 11 o'clock on the West Coast. And also, and more importantly on my end, my wife and girls are out shopping, so I'd like to wrap this up as quickly as possible so I can beckon them home and protect my bottom line. So we will, if my slides want to advance. So we're going to cover standard of care recommendations for the Walker population. We'll do a little bit of comparison and contrasting like we did yesterday across the three phenotypes that we're discussing here. We'll point out some of the ways that we alter our evaluation and the ways that we alter our interventions to meet the varying needs of our patient populations. And then, of course, illustrate this with some historical cases as well as new treatment error cases. I made a last-minute audible and about 5 minutes ago reordered the three case series. So hopefully it's a nice, smooth transition. I get through the slides, but I think it'll have a little more dramatic effect how I reorder them. So primary rehab goal, again, whether this is for a sitter, a non-sitter, or our walking group, is we want to maximize the independence in ADLs and the efficiency. Now, the big difference in this group here is we're really at the macro level. We're really looking at this top-down approach. These patients are much more functional in general, right? Much less impaired. So, their functional level and how much they participate in their environment is going to be much higher than the other two phenotypes. So how we look at them, how we evaluate them, and what type of interventions we have are going to be a little different. The other thing that I think is a little different is the advocacy piece here. So because these kids are more functional, and if you work amongst different neuromuscular diseases, you'll see that there's variations in the level of impairment and kind of how visible these impairments are. So for our children who are in wheelchairs, or walk with a walker, or have crutches, or have ataxia, this is very obvious to people in the community, teachers, coaches, peers. For our kids and adults as well who are more functional and have these subtle impairments sometimes, this is a lot less obvious and can lead to various challenges. So I think there's definitely a piece of advocacy and the ability to teach them how they can educate others about what may be challenging that should be part of their care as well. The lens that we look at these patients through, again, is a little different. So if you think back to our our non-sitter population, sometimes we get tunnel vision, right? We get very microscopic detail. We want to look at that thumb, and we want to hyper-focus in on the thumb or the index finger and figure out how much it can move. Or if we change the position of the wrist or the forearm, if we support them differently, right? How can we maximize this very microscopic thing so they can then operate their joystick, or they can use the touchpad, right? We may look at what's the best way to support their head and trunk so they have good postural control, and work on eye control so they can use eye gaze software. And then as we work up to the sitter group, it's a little bit of a combination of these microscopic level things that we kind of focus on, but also the macro level. What are they doing functionally? Where are they? And kind of trying to marry the two in between. When we move to the ambulating group, which we're going to look at today, it is more of that macro level. We're not as hyper-focused on the individual impairments necessarily as a means of how we're going to address them, but more how are they using the tools they have? How are they using their strength? Where are they at functionally? And what do we kind of have to do? How do we develop a program specific for them? And then again, as we saw in the other two phenotypes, there is variability within each group in their level of impairment. So there was wonderful talks this morning that took you through the life of the ambulator and showed change over time, so I won't spend any time speaking to that. Again, briefly, on a few of the slides, you'll see these table over here to the left that ranks in the order of importance from a previous session, types of symptoms, interventions as they relate specifically to the three phenotypes. And again, we kind of shuffle the deck and we move these things around to fit the phenotype of the patient, so where we focus our priorities. So when we look at the upper extremity and the person as a whole, in this ambulatory group, this proximal weakness in the shoulder really leads to difficulties with reaching outside of their environment, lifting and carrying heavy items, maybe having a backpack on and going up and down the stairs, maintaining the arm in space for extended period of times. And then when you think to sports and leisure in the work world, how much force can they generate? How efficient are they? And how do they endure, right? Are they fatiguing? And does your performance change over the course of the day or after exercise? And that's approximately. Distally at the hand, although the range of motion is usually completely normal from an active range of motion standpoint, this weakness in the hypermobility that we talked about yesterday leads to an inability for tough resistive activity. So opening containers, jars, bottles, maybe difficulty cutting your food. So there's a real opportunity here to use some of those adaptive tools and compensatory approaches as occupational therapists that we're used to using, so we can kind of bridge that gap while we try to remediate in other areas. So how does our evaluation change? So again, thinking about this top-down approach, the patients are generally very capable. So we want to see what they can do. We want to, if you use a PRO ahead of time, that's great. If the patient can identify ahead of time what their level of ability is, and you can pinpoint the two or three things they struggle with, for example, and then go into the room as part of your evaluation and observe those directly, that's a very efficient way to do it. If you don't use a PRO, right, you could do your traditional interview, quickly find out what it is, and then the evaluation of, say, putting a shirt on or taking a shirt off in a patient like this is very valuable, because you can see where that gap lies. Additionally, we want to continue to use SMA-specific outcome measures. So for the upper limb, that's the RULM. We'll talk about some of the strength and some of the challenges with this population with the RULM on the next slide. And then now in this treatment area, really the shift towards norm reference outcome measures. So based on the age, for the younger kids, looking at the Bailey and the Peabody so far, these two have been started to be used because, as you've seen through these wonderful talks and the treatments that are available now, these kids are starting to approach or nearing normal developmental milestones, and we hope that this continues, and we really need measures to capture this change. Additionally, I'll show you some data on the 9-hole peg test and myometry that we've used at CHOP, and some information from our retrospective study at CHOP that we're doing currently. So the RULM, quick refresher, right? This is the upper limb scale, looks at functional workspace, reach of the upper extremity, how far they can move, what type of load they can move, and how their distal motor skills are. To the right here, again, it does a nice job differentiating between the different types of SMA, even between our ambulant and non-ambulant type 3 groups. This is data from, again, I said, a retrospective study at the Children's Hospital of Philadelphia that we completed. You can see very different from our sitter group, that the mean score was around 12 or 13 for the group. The mean score of this group is 30, right? So the performance is much higher. They have the capability, they have the proximal strength to reach through larger ranges of motion and move and lift heavier objects. However, you can still see that there's a fairly good distribution of scores amongst the group. So it's a good thing to look and administer. Again, use as your starting point. You've done your ADL screen, observe what they can do, and now you can do the RULM to capture where they are along the continuum. However, as you can see here, the top end score on the RULM was 37, and there is this potential of a ceiling effect. So why this may be problematic in one case, right, from a statistical standpoint and looking at the group, this is actually a good thing, right? It's a good thing because it means our patients are getting stronger. These disease-specific scales that we created to meet their needs as they have these, therapies, and therapy meaning treatment with medicine, but also occupational therapy, physical therapy, nutrition. As we're meeting their needs better and better, and we're getting stronger, more functional kids, which is the goal, we have to look at transitioning to other outcome measures to continue to follow their progress, and so that we have the ability to monitor how our treatments impact them over time. So the box and blocks we touched on yesterday. I'll show you another video today of an individual with SMA type 3 who's ambulatory. Unlike the young lady unlike the young lady yesterday who had a hard time lifting the blocks, had to use a lot of compensatory movement, you can see her performance here is very different. Okay, we'll watch this a few times. Her trunk is very stable, right? Straight up and down. There's no lateral deviation. There's no movement. She has the endurance and the strength in her shoulder to keep the arm abducted in place. She doesn't have to rest the forearm on the table. She can quickly grasp and release and move the blocks over rapidly, right? So in this case, we're not going to, we may see some fatigue, right, from minute to minute, and that's good to observe. And we may be able to track that with a block count from minute 1 to 2 to 3 and kind of capture some of that endurance. But what we can also do is on the other end is we can capture improvement. We can look over time, over subsequent visits, how their performance is changing. And I'll show you that in another slide. So how else can we use norm reference assessments that we're all very familiar with? So I'm sure every OT does grip strength, 9-hole peg test. These are very standard issue things that have been done in the OT world, the neuromuscular world for a long time. You know, I kind of downplayed the importance of some of the strength testing in the sitter population yesterday in terms of capturing, you know, the force production, because I think there may be a more valuable way of doing that, looking at range of motion. However, it's very different when you look at this population. So again, based on the phenotype of your patient, and then you really need to decide what measure is going to best capture where they are and track their change over time. So this, again, this is retrospective information from our SMA type 3 ambulatory population at CHOP. On the left here is their grip strength. So the mean grip strength for the group is negative 2.61. So still as a group, right, this cohort is far below age expected strength, which is not surprising. However, when you look at the chart and you see here's the mean for age expectation, you know, we do have a fair number of kids who are to the right of that mean. And then also, if I approximate here where that +2 would be, right, we do have a few positive outliers who are actually stronger than you would expect for their age. And these are kids who are baseline stronger, type 3, later diagnosed kids who are now on treatment and are actually excelling past here. So I think the trend that we're going to see, and you know, we plan to look longitudinally moving forward, is that hopefully this mean trends over time and moves closer and closer and closer to back where we would expect for kids of their age. So if you're working on strength, this is a great way to capture changes over time. It's also a great way to show how kids are responding to therapies. 9-hole peg test as well. So again, as a group, you can see kids with SMA are just slightly below average. So the distal hand skills and the fine motor skills in this population are pretty much intact. There's still variation among, right? Again, the x-axis shows the z-score. So there's still variation in how they perform, but still a good measure, approximating normal and something that we can look at to capture their change over time. So what do? Do we remediate? Do we try to get these kids stronger? Do we work on flexibility? Do we work on endurance? Do we do an adaptive compensation approach? So again, just like yesterday, the answer is both. I think it's a little different. I talk about like what's the hierarchy, what's the proportion. You know, depending on the patient and how they present, you know, we have the opportunity in this group that is more functional at baseline to really take a more aggressive remediation approach, but we still want to take these opportunities to provide adaptive equipment or compensatory strategies that we identify during their ADL screen that can help them establish their independence. If you have time to look, there was a wonderful Cochrane review done by Bart and Jackie and others on exercise training for type 3 SMA. You know, not unlike many other pediatric conditions, the findings were that there's not enough high-level evidence. We need more studies to support this. They can either confirm that, you know, the benefit or that there's no harm. So this, again, you know, as pediatric therapists and also as adult therapists, I'm sure, this is a familiar finding with these reviews in the area of rehab that we need more research. We need more data to support these interventions. So when you hit a roadblock there, the next step is to do what's called a Delphi process. And, you know, very briefly, what this means is you establish a panel of experts in the area. You establish a list of questions or consensus statements. Each individual in the group rates their level of agreement on a numeric scale. There are certain parameters that list what the mean agreement has to be above, how much variability can be between the highest and the lowest rater, and other factors that eventually at the end what you get is you get a consensus statement on what is best practice in this area. So to the right here, you can see what was this Delphi panel resulted in and what should we do for aerobic and general conditioning exercises. So swimming, aquatic therapy, which we've talked a lot about, upper extremity cycling, yoga, right? Great for core strength, flexibility, balance, rowing, elliptical. So a lot of these exercises, cycling, rowing, elliptical, right? These are concentric exercises where the muscles are shortening in both directions. So we know that these, from other neuromuscular diseases, they believe these to be less damaging to the muscle and safe. We want these kids breaking a sweat at least 30 minutes a week. 3 to 5 times a week is optional. There is value in, not only just reading I'll pull it up again, not only just looking at the Cochrane review, but also going back and looking at the papers that are referenced or involved in the study. There's papers on various phenotypes of SMA, what the strengthening protocols are, and what some of the positive changes that were made. So I feel very strongly that strengthening should be an approach for this population. I think it's just a matter of the time that we have to provide the data to support that. So how do we remediate and adapt for this group? So the first thing is environmental modifications and adaptive equipment. If you think about where you place items, so since the weakness in the upper and lower extremities is predominantly proximal, what's going to be hard? It's going to be reaching up and away from the body, and it's going to be squatting down to get low items. So take those frequently used items in the kitchen, around the house, right? Move them between knee and mid-chest levels so you're not reaching too high or squatting too low. You can lower the clothing rack in the closet where the clothes hang so the kids are able to put the clothes up and down. Often from older patients and adults who are doing laundry, carrying things around the house that may need an arm to hold, or 2 arms, right, to hold the guardrails. They go up and down the stairs. There's different backpacks that are out there, laundry bags, things that can kind of free the arms up. So thinking about how can we free them up. And then every Bed Bath & Beyond and home goods store in the world has ergonomic based equipment for jar openers and things like that. So now we're going to move on to PREs and what this means. So, PREs in this ambulatory group is far different. So it's still based off of the same elements of our non-sitters and our sitter group, but it's really a different approach. So instead of looking at, for example, in the aquatic environment where we're going to be doing active assistive, using the resistance, using the buoyancy of the water or using the drag of the water to help assist the arm move, right? And then we're going to grade over time to where maybe they can move on their own. And then possibly we use the water as a little bit of light resistance as they still move in a gravity-free plane. This group's going to be the other end of the spectrum, right? We want to look at their load differently. Do they have the strength where they can go and they can do traditional, dumbbell, barbell, resist the band exercises? If they're a little bit weaker, maybe they just need to use the limb itself, okay? Or maybe we need to use some other strategies to get them there. Also, again, thinking about the discrepancy between strength in different muscle groups and knowing that the biceps tend to be a much stronger muscle than the other ones in the upper extremity. There's times where we may need to use grip assist devices if their hand strength isn't strong enough to hold the load that they would use for some bicep work or some other muscle work. So active hands is a great device for weightlifting, gardening, any type of activity where you need to keep a sustained grip that you might struggle with is very good. So I initially diagnosed for patients with spinal cord injury who had good proximal movement and very little distal hand movement and fine motor skills. So our patients are ambulatory with SMA have more than enough fine motor skills to put this on and utilize it if they need it. We'll touch on working range again, not as much as we did in the sitter group, but briefly as well. So I shuffled the order here a little bit. So instead of starting with the infant, we're going to start with the child/adolescent. This is our traditional, right, historic patient with SMA type 3. He was onset of symptoms was 2 years old. He was diagnosed at 3 years old. He's ambulatory. I will play the video so you can see here. He has considerable weakness in the upper extremities. He has very little true active movement at the shoulder. He uses a lot of compensatory movement strategies to elevate. So you can see he gets a little bit of flexion, a little bit of ABA deduction. He is asymmetrical with the right side moving more than the left, right? However, he's able to get his hands to his mouth, right? You would look at this and probably think with, the amount of weakness that he has, with the amount of compensatory movement that he has to use, that he's probably not a very functional kid, but we'll see that that's not the case for him. So in terms of impairment, and we'll compare and contrast a little bit to the 2 other groups we talked about. For his myometry, elbow extension, right? 1 pound. Elbow flexion, where's elbow flexion? My old eyes here. All right, not finding elbow flexion, but but a pound of strength. So again, upper extremity is very weak. Not a great assessment tool for him, but just wanted to use this to illustrate how weak you can still have ambulators be at times. Grip strength, right? 6 pounds, 6 pounds. So far more than we're seeing in the non-sitter group, which can't register force at all, right? And still even far more that we're seeing in the sitter group, where the outliers in the sitter group were around the 4 or 5 pounds of grip strength. And here he is with 6 pounds, but still far less than we would expect for a boy his age. And this is his lateral pin strength as well. So again, far less where he is. Enough that he can operate a joystick. He can push the buttons down on his phone. He can use the remote control. He can plug and unplug his phone charger. So enough strength for functional things, but still very weak. So from an activity standpoint, you see here all these limitations in range of motion. What's that mean? Difficulty raising the arms. He also had distal weakness as well on the hand, limitations in extension of the fingers. So he had pretty severe upper extremity presentation that impacted him globally. However, when it comes to his participation level, he was very independent. This is, out of all the kids I've seen in neuromuscular clinic in my 18 plus years at CHOP, he's by far has the largest discrepancy between what I saw, what my expectation of what he'd be able to do and what he can actually do. So he compensates so well, uses his body and momentum and techniques, and he's really learned to how he can function in space so that he can maintain his independence. So fully able to dress himself, undress himself. He did some cooking around the house. It didn't always look pretty, but the end product was there. So his limitations were, as you can imagine, retrieving items, like we said, opening up things that were resistive. He had some difficulty in class with fatigue and handwriting, and then he loved to play sports. He had 3 younger brothers. He loved to throw the football, have a catch, shoot hoops, and kind of do everything. So the challenge for him is trying to figure out how to close these gaps and where are we going to start. So we really wanted to, we really focused long-term, even though we have short-term goals here, long-term goals. The focus for him, honestly, was long-term. How can we have a starting point where we can set him up with a community-based program that he can carry out and hopefully over time make gradual incremental improvements that are going to improve his efficiency of movement a little bit, maybe decrease the need on compensatory strategies as much, maybe just sustain, and again, in this pre-treatment age, sustain his level of performance. So we took him in the pool. I'm going to show you very briefly how he does in the pool. These are just a couple for reference. I'm sure Kim talked about these earlier, but some terms you can reference to learn about. You can see the striking difference in how he can move in the pool versus on land, right? Still needs to flex the elbows on the way up, right? Whole AB duct a little bit, and he still has to flex the elbows to get full abduction, but can really get good work here in supine to work on the strength in those shoulders and then the strength in the lats on the way down. And then additionally, this is a leisure activity. We want a lifelong leisure activity, something he can do and pursue and enjoy on his own. That's fun, but also has a rehabilitative benefit. Our land-based sessions really focused on adaptive equipment, compensatory techniques, and we did do some upper extremity ergometry and some scapular stabilization work. He had a dorsal wrist cock-up splint that we used that kind of helped power his grip. His left hand had really limited motor skills. He had significant wrist drop. So this allowed him to stabilize objects, like when he would hold a bottle to try to open it up, or when he would hold anything for two-handed manipulation. Okay. My next patient is our adult patient, 22. She's not an adult here, but this is the only video I had from her when she was a cute, adorable little 6-year-old. Now she's a beautiful grown woman. It'll just kind of illustrate some of this proximal weakness that you see, right? So you can see the proximal weakness in the hips, in the shoulders, right, when she runs. So initially, her onset was at 7 years old. She reported leg pain, some weakness in the hips, difficulty getting up the stairs. She was diagnosed shortly after, began albuterol treatment at 10 years old, and then 19 started Spinraza. So here's information from her, one of her fairly recent evaluations prior to our home exercise program. So shoulder flexion, 130 degrees bilaterally, right? Abduction about 60 degrees. And then if she flexes the elbow to shorten the lever arm, she can get to 140. So again, right? We captured two degrees of measurement here. How far in true abduction can she go? And if we allow her to kind of shorten the other arm, what can she get there? So we can follow the two of those. And distally was within normal limits. Her strength, right? So you can see her strength far more than our other ambulatory patient with SMA3, right? She's got 5.5 pounds versus 1 pound, right? Our elbow flexors have 10 pounds. So still somebody who can produce fairly good force. But again, if you look at the elbows, her strongest muscle group, where she has 10 pounds of flexion, still way, way, way below where we would expect for a female her age. Okay. Activity limitations. So we moved on to the RULM for her. She did very well in the RULM. She scored a 36 out of 37. So this is where it becomes problematic, where if you stop here, we don't have any other measures to track her beyond this point, unless she's going to regress. And the hope now that she's on medicine and knowing her clinically is that she's not going to regress. She's been making steady gains, and I'll illustrate some of those in the next slide. So we've been doing the box and blocks with her for a few years now. This is data from her most recent visit and the visit prior to that. So you can see on the left, right, here's the minute intervals for the dominant right hand, the non-dominant left. The number here, these are the number of blocks that she can move in 1 minute. And here was her previous visit. So you can see she went from 111 blocks to 190 for the dominant hand. So almost doubled, just shy of doubled. And the same for the non-dominant, from 120 to 205 blocks. So even more impressive than just the raw number is if you look at the Z-score. So this is normative reference data for 20 to 24-year-old females. So this is a four-year range. So we're not anticipating that at this age, there's going to be any developmental change, any significant naturally occurring because of the natural history of 20 to 24-year-olds strength or endurance changes that are responsible for this. So her Z-scores jumped the whole Z-score from -4 to -3, and then the non-dominant even more, -4 to -1.92. So this really shows the power of, the Spinraza treatment, the therapy, the home exercise program she's getting, that this individual was able to not only have some raw changes in data, which would be obviously significantly different if you ran some basic statistics, but also from a Z-score standpoint is a tremendous jump in a short period of time. So I really think, and again, we're going to look at more of this data that we have with this assessment. I think this box and blocks has the potential to really provide to be a great tool for the patients that are in this area where they're going to have a ceiling effect on the RULM, and it'll still capture some of that proximal performance. And then finally, her 9-hole peg test, you can see she's in the low area of normal. So again, this is a good one that we'll follow over time and anticipate if there's any changes there. She's fully independent, all ADLs. She works 30 hours a week in retail. She enjoys sewing, baking, and exercise. So really, when you think about limiting factors for her, it truly is how efficient is her movement? Does she fatigue? Is she at the end of her shift? And that's what from several visits we talked about. She was able to stand longer. Her feet weren't as sore. She didn't need to take as many breaks. So as she progressed with her home exercise program, which she's very diligent at, and she's got great equipment at home. She has a treadmill, she has an elliptical, she has weights, she had bands. We really started to see this take over in terms of how productive she was and how successful she was in her environment at work, which is what we want. So what did her program look like? So frequency from a strengthening standpoint, 3 times a week. We started slow with 1 exercise per muscle group. We just wanted her to get the basics of the movement down, how to activate these movements and develop those movement skills. 8 to 12 repetitions, space between the workouts of a day, and 1 to 2 minutes rest in between exercises, unless of course it was an alternating thing where she did one arm first and then the other arm. Important is varying the strength, varying the load and the type of movement based on her strength. So the next slide, I'll show you how we kind of did that. And it's not sufficient enough just to kind of set them up with a program, but we also have to educate them on progression. So when would you progress? When do you increase the weight? When do you adjust your angle? When do you decrease your rest time, right? So all these factors that we have to manipulate to change the intensity of a workout. Traditionally, we want to teach our patients that are doing strengthening protocols how they can manipulate those as well so that they continue this muscle hypertrophy and growth.
Hi, Tim. It's about 2 minutes left.
All right, I'm going to go over. All right. We have till 2 o'clock, correct? Yep. All right. So So progression, how can you progress it, right? So I talk about these: heavier weight, different grips, thicker bands. So for her, in the past with shoulder weakness, we did some place and hold exercises where we would place the arm in abduction. She would work on an isometric hold for a second or two, and then eccentric can control it down. Once she began her Spinal treatment and her home exercise program continued, we were able to go to some body weight stuff with the shoulder. The elbows are a little stronger, so we were able to use a 1 pound dumbbell for the left and then a 2 pound dumbbell for the right. So again, one arm stronger than the other. We do not want her working with the same load. So you have to look at that. And then you guys can reference all the individual specifics here yesterday, because I want to get to in the future, because I want to get to the next case study. And then we did a band press down with her as well. So we looked at these prime movers of the upper limb, at the shoulder, the elbow, the tricep, and we established what was the specific load and the type of movement and the type of contraction that she was ready to work at, and then how we progress that. But it needs to be different, or what doesn't need to, it may need to be different at different areas. So you need to consider that. All right, so what was the result? She came back 20 years old. From one visit to the other, as I already showed you, she increased her grip strength, her pinch strength, her 9-hole peg test time, her box and blocks performance, her RULM score improved, and she's feeling better at work. So again, I wish I could say this is all due to my home exercise program. Obviously it's not, that's a part of it, but also the treatment she's receiving as well. So we really want to maximize the results of these patients and establish these home-based programs. And finally, the last one I'm going to do, that I move to the end, because this is, from my experience, the most dramatic thing that if you haven't worked with kids SMA and you're seeing now, is still surprising. And if you've done this for your whole career and you've seen this changing phenotype with treatment, it's quite remarkable. So this young lady, Celine, is a now 29-month-old female with SMA type 1. Right? So remember, these are kids who have a high probability of dying or being on ventilation by the age of 2 years, don't sit, may not roll. All right? And you're going to see it's much different with her now. So 5 months old, mom noticed difference in baby yoga, how she was moving. She was diagnosed at 6 months, immediately began Spinraza and then Zolgensma right after. So very early, was not pre-symptomatic, was symptomatic, but caught early and initiated therapy very soon. Initially, we looked at her, had limited shoulder flexion, but good distal movement. You can see the postural control here, right? Flopped right over, so still weak trunk, weak head control. She was unable to roll and stuck on her butt, so her transitional movements were limited. Okay, and then I have different spots of her treatment, different videos. So later on, you can see she's much stronger now. She's on treatment. She's doing well. But if you notice, when she goes to move, right, she's got her elbows fully extended, almost hyperextended and locked out. So she doesn't have the strength in her triceps to really bear the weight. When her weight is shifted back and both legs are on the ground, she can maintain herself. She can advance the arm. Once she tries to get those legs up and shift the weight forward, she falls forward. So she doesn't have the strength in the arms yet to sustain that movement. So what are we going to do about that? And how does this impact her? So first off, for an infant, the inability to crawl, right, really limits what you can get to, what you can explore, how you can play in your environment. And then frequently now that she's older, right, very impressive here. Here she is trying to step up onto the curb, which would have happened within 1 to 2 seconds, right? A typical 2 or 3-year-old. And you can see the labor that it takes for her to get up. So while this is extremely impressive for someone with type 1 who's doing very well on treatment, you can still see this is far from what you would expect in a typical 2, almost 3-year-old girl. Okay. These were her goals. Intervention. So just like our other patients, right? Supine, great spot. She doesn't have to maintain her head and trunk control. She can focus on the use of the arm. As she got stronger and is able to stand, now we can have her start moving that arm against gravity more while she's still maintaining some sense of control with the left arm. And then eventually we can have her do lateral upper extremity reach. So it's very common that kids can move one limb more than the other, or if they move only one limb, they have a larger range. But as they have to stabilize the trunk and move both limbs at the same time, they cannot move the limbs as far as they can when they're one at a time. So this just kind of shows the progression of how she did, but also how you have to progress the challenge in the therapy to facilitate this growth. Okay, prone skills. What are we doing for prone skills? So in the beginning, very helpful, right? She's cleaning up after dinner, but this has given her the opportunity to do short range trunk work, right? Back and forth, forward and back. It's also giving her the chance to protract and retract with the scapula and also get a little bit of tricep work. So this is a good starting point. As she gets stronger, we can move to some partial weight bearing where her body's on the floor. You can use towel rolls, boppies, different things to position and let her take some weight. And then eventually, right, she gets to the point where she's doing this lovely plank. Now her game's not as strong as mom's, right? Mom's all lined up, right? She's still got that booty a little high, but as she gets stronger, right, that'll come down. The weight will shift forward and she'll take more weight through the hands. So as she progresses, right, we progress what she does and we increase the demand, but always keeping it where she's successful. Intervention, right? So we talked a little bit yesterday, and we'll talk now some about concentric, eccentric, and isometric. So, and this is lower extremity stuff, but we can attribute the same thing to the upper extremity. And you'll notice that her eccentric control was poor, right? It's very challenging for her to control the descent. Now, the benefit of her being in that bathtub is that she might have difficulty with the descent. And then when she's at the bottom and we're working concentrically, even though her quads are over lengthened, and that's going to be a very hard spot to initiate movement from, the buoyancy of the water helps propel her up. So ideally in a land-based session, right, for this squat, they'd have a stool or something underneath where she would only partially squat down and then come back up. And then you would reverse, right? You would do those partial range reps until she had the strength where she could go all the way down and all the way back up. And the same is true for the upper limb.
Tim, do you think we can wrap it up?
Here's what's video. I'll show you again. Her climbing up, right? So getting the hip flexion, really using those arms to pull, having the weight forward, and then back up. And this is where she gives everybody a heart attack. Went up, I cut the video too short. She lifts both arms up in the air, and every time I watch, I'm afraid she's going to fall back. But, I put this in to kind of illustrate the difference between, observation-based scales and norm reference scales. So from an observation-based standpoint, yes, she can climb up onto the sidewalk, right? From an observation standpoint, she can do a squat to stand. But when you cross that threshold, it's very important to look at normative-based data and normative reference-based data to continue to see that progress, because her performance here is still very different than what you would anticipate in another girl her age.
Tim, we have just 10 minutes for Q&A.
Okay. All right. I'll be done in a minute. All right. So DME here, right? She had standard baby stuff, boppy, a wedge, bumbo, an activity chair, and the otter root here for the pool. So I say this for last because this is really very powerful stuff. Every time we see her in clinic and we see the things that she's doing, it's quite remarkable and very, very different than any SMA1 patient that we've ever seen pre-treatment area. I'd like to thank my families again, as well as Nancy Green for helping with the retrospect data. And again, my family as well for supporting me in all my endeavors. And now we have 10 minutes for questions.
Thank you so much, Tim.
You're welcome.
So if you have any questions, folks, feel free to type them into the Q&A and we'll be happy to answer them for you.
Nothing coming through?
No, and they're almost all the attendees are still here. So
okay. Come on, like I said yesterday, I know I don't make sense all the time. Kim tells me that quite frequently. So you're either proving to me that she's wrong and I do make sense, or just ready to ask. Is there anything you want to look at again? Any questions on the assessments? Any video clips that you think would be beneficial to look at? I certainly could speak. I could speak for 30 minutes on some of these individual video clips. So if there's anything that you want to talk about more, I'd be happy to do that.
Okay, looks like there's a question. How much education do you provide your community therapists that are working with the school therapists?
How much education? Say that again. I'm sorry, I'm trying to process that.
How much education do you provide your community therapists that are working with the school therapists?
How much education do we provide the community therapist that's working with the school therapist? So I think, one of the biggest challenges is getting the information out there. Conferences like this are extremely, extremely helpful for disseminating information to the community. Really, our only true link between the patient, the community, the school, between the school therapist, community therapist, is the patient. So often what we do in clinic is we give our contact information, have the patient sign a release, and then unfortunately kind of wait for them to contact us. Without the patient's consent, we can't go and contact their community therapist. How I do that, we've had phone calls, we've done like FaceTime during sessions. I've shared presentations. So it's something we're always very happy to do. It's something, honestly, that is hard as the clinic provider because we can't be the driving force behind that. It has to be the patient/family and then the community provider reciprocating. So I'm not sure that I understood completely what the question was or that completely answered. So if you want to clarify, I'm happy to speak more. But I think the biggest thing is having resources available. So the Cure SMA website is very helpful. The MDA website is very helpful. Again, like I said, information and presentations from conferences like this that live on. These are all tools that we try to provide the family with so that they can then educate the people around them. I often talk with families about expertise in the community, and I kind of say that it's very likely that the therapist that you're going to see in the community may have never heard of SMA, and that's not necessarily a problem. They have two approaches. They can ask questions. They can begin to learn. That gives you an opportunity to teach them. Now, if they have no interest in learning, if they're not listening to information you're given, then that's the time to fire a therapist, speak with the agency, and find someone else. But just because someone doesn't have experience or doesn't understand, doesn't know, doesn't mean that's a bad thing. It gives an opportunity for the patient and the family to serve as educators or to connect them with us so we can serve as educators. Because we know we're limited in our capacity to treat these patients. There's a very, very small percentage of patients that Kim and I see in clinic that we're actually able to treat because where they live geographically, when they can come in. This whole thing really is about empowering the people in the community and educating the community so they can provide the same level of service that we do at a specialty clinic.
Okay, we have more questions. So do you see the clients after they get a dose of medication for a burst of treatment?
Sometimes. So by do we, meaning us, so we'll see the patients in clinic for a reevaluation after treatment. At the initiation of the treatment, again, like I spoke yesterday, we try to get them at the minimal into outpatient therapy and extensive home-based programs. There have been times where they do a day hospital or inpatient rehab stay as well. So I think when someone's initiating treatment, we really want to get a good evaluation, see where they are, and then figure out what's going to work best for the family. Again, this is a long-term thing, right? And I think some of the testimonials we saw from the patients really explain this when you're thinking about every 4 months for the rest of your life. So we want to capitalize when the moment's ripe, so when they begin treatment, and then we want to think about how this is sustainable for long term, because 3 or 4 times a week in-person therapy with a clinician for the next 4, 5, 6, 7 years isn't really a sustainable thing for very many patients. So yes, I think it's good to get a burst. I think the biggest value in the burst is not that we're providing the hands-on therapy, but that it's giving them a lot of time with us for us to educate and then empower them to be able to carry this out with their community providers, with their parents at home, in the school and in their environment, and then they come back to us as they progress and change. So each clinic visit, we're trying to figure out how we're going to tailor those visits moving forward, to tailor those program moving forward.
Have you provided oral motor feeding intervention for any SMA patients?
So the only things that a few things we've done, the Therabyte is one. We've noticed some of the kids with SMA end up with TMJ contractures. So we have a therapist that works in our facial motion clinic that we refer these kids to for the Therabyte. We've talked about chewing gum, blowing bubbles with some of the weaker patients and the younger kids using whistles. Forget what things are called when you blow on them, they spin around. I'm blanking on the word.
Pinwheels.
Pinwheel. There we go. But I'm very excited. We now have a speech therapist that's in clinic, and I'm hoping that this is something that she'll be able to add to. As it's not our area of expertise, but we've tried to jump in and help as much as we could.
Where do we access the RULM and what is the cost and training?
So you can reference, I have the article in the presentation. You can, the article's free to access. The ROM is not sold as a kit. It gives an equipment list. You do have to kind of go on Amazon and a few places to put it together. Kim, do you remember the cost? I don't remember roughly what it.
I think it was around maybe like $50 with all the items on Amazon.
Well, the only thing, yeah, listen, it's not like a Peabody. You're not dropping like 1,500 like a Peabody. But the weights, the weights are expensive. It's a little bit more of a hassle to find the individual equipment, but it from a financial standpoint, it's far more accessible than that. In terms of training, you'd really be looking at identifying someone, in the area near you or virtually. It's something we can certainly do virtually. And there is, there's a very good manual. You can reach out to me. I can give you, there's a manual on how to, administer and the positioning of it and how to do the items.
Okay. What do you recommend for equipment from an equipment standpoint or DMO, SPO for scoliosis?
So I've done nothing in that area. The PT that I work with handles that. I know he's been referring patients lately to one of our sports doctors, a sports therapist that does the Schroth method, I believe. But not something, we kind of divide and conquer a little bit in clinic. So not an area that I've been directly involved in, but I know that's what he's been doing recently with the patient's scoliosis.
Okay. Any recommendations for sources to learn bathtub aquatherapy? I can answer that. Right now, I'm working on a document that I can just send out to people. I've had a lot of interest after doing the first talk with the SMA1 population. Really, there are no sources out there right now. It's more just learning the properties of the water and how you can use them appropriately to elicit what movement and strength that you want from the patient. So I can have that resource available if you want to send me your email. Okay. Did you say that there were norms for the box and blocks tests? Where can you find it?
Yes. So there's several different normative reference groups. There's one paper that's 3 to 10-year-olds. There's another one that's on adult that started 20. There's a targeted box and blocks norm. So there's several groups out there. You have to use your local. You can check PubMed, or if you have access to a university library that your hospital, university you're affiliated with. Or if you don't, honestly, the best thing is that as you have students come through, because it's quite expensive for hospitals to get access to good medical libraries, as you have interns, students come through, they'll still have access to their library, is utilizing them as a resource. But they are available online. I have the one paper on 3 to 10-year-olds. The citation is within the presentation that you can look. But the others, like I said, you'd have to have access to the library.